getting us started, and I want to say thanks to Roger and Stan and to everybody who has put this together. It's just a tremendous amount of work that goes on behind the scenes to make something like this happen, and I agree with Glenn. I think this is just a really important part of our field that really needs more attention, and will open up just a phenomenal world of opportunity for those who get involved. So my talk, this first talk, is on M6 for the phaco surgeon, and we can go to, do I click the next slide? Do I have a clicker myself?
Just the forward button on the right, forward right in there.
Oh, I see. Am I missing something here? How do I forward my slide? There we go. Okay. So, some questions to kind of address on this talk is there a role for M6 in developed nations? With all of us, we have access to all this modern equipment. Is it wise to have an alternative or a backup for phaco? When I trained, I also trained first in standard extra cap. We had to do 50 standard extra cap before we could do our first phaco. The idea is we needed a backup if phaco didn't work. These days, that's not happening in residencies by and large, I would say. And how might M6 be used in complex cases that make phaco a challenge, even here in this country? And might M6 actually be a better choice than phaco in certain situations? And then, do you have an alternative to offer your patients who may need it, both here and abroad? So I'm just going to dovetail a little bit on what Glenn said, that M6 is not an inferior procedure to phaco. It's not better, it's not worse. The outcomes have been shown to be equal. So it's a different approach and better in some circumstances, and maybe phaco is better in other circumstances. But this is just one of a number of studies that have been done. This was done by Dr. Rui, Dr. Chang. It was a study of comparing phaco and M6 in Nepal. It's been a few years since it's been done, but basically just compare the efficacy and visual results of phaco versus M6. And the results showed that on post-op day 1, both groups had comparable uncorrected visual acuity. M6 had less corneal edema. That's not surprising. They had zero phaco energy and dense cataracts. At 6 months, basically the uncorrected and best corrected visual acuity were equivalent in both arms of the study. And the surgical time for M6 was much shorter than it was for phaco. So they concluded that both phaco and M6 achieved excellent visual outcomes with low complication rates, and that M6 was faster, less expensive, and less technologically dependent than phacoemulsification, and that it might be the more appropriate surgical procedure for treatment of advanced cataracts in developing countries. So for us, as phaco surgeons here in the US, I think developing a proficiency in this technique gives the phaco surgeon an alternative to phaco that can be useful in a number of clinical settings. You come in, a patient with the mature cataract there can walk into your clinic here. I see a number of mature cataracts every year in my practice in southern Minnesota. You might be wanting to take a mission trip, and you'll want to use those skills there. Or how about this patient on the end? They walk in, you're going to phaco that? I don't think so. So what kind of alternative do you have other than your phaco machine? So here are some possible indications for planned M6, here even in the United States. Dense brunescent black cataract. Maybe it's a Fuchs patient with a mature cataract. I had one case that I sent to a cornea specialist. I assumed she was going to get a combined procedure, and there's an elderly patient, and in order for her to get a corneal transplant or a desec, she was going to have to drive an hour and a half each way up to a metro area that's outside of our area. Her daughter would have to take time off of work, and she decided it wasn't worth it to her. She couldn't make that logistically happen. So the cornea specialist sent the patient back to me and said, I think if you do an M6, she's going to be okay. And in an M6, she did beautifully. So it's not somebody who would have phacoed just from the standpoint of her cornea. Subluxation of a crystalline lens. M6 can actually be a very excellent procedure for that. It's not that complicated of a procedure. If you can get your lens back just underneath that loose lens and just lift it out, put an anterior chamber lens in, it's actually not routine, but it's not that difficult to do. Known zonular dehiscence or phacodenesis, predictably more complex cases. Maybe you had a pseudoexfoliation case that didn't go well the last time. Maybe you want to plan to do something differently so that you're set up for potential problems that might come in with your zonular dehiscence. And a lower cost alternative to higher tech approaches. Unplanned M6. This is where it gets a little exciting. This is where you start out with a Phaco. You think you're going to do your standard Phaco procedure, and something happens where you're not able to complete the procedure as you started. One of these situations is intraoperative subluxation of the crystalline lens. So I just saw a post-op patient from about 10 months ago yesterday, just coincidentally before I came down here. And she was a lady I started out with. She had a relatively small pupil, pseudoexfoliation. I didn't pick up that her lens was loose though. Did my Rexus, and I just started to do my initial groove, and that lens, the lens just hung on a few zonules. Didn't fall into the back of the eye, but it was vertical. So I've got my 2.5 millimeter clear corneal incision. I don't think I'm going to finish that with Phaco. So I converted that wound to an M6 wound, went in with my lens vectus, took out the nucleus, anterior vitrectomy, anterior chamber lens, and 15 minutes later, 20 minutes later, a little longer case in that case, I'm talking to her in the post-op area. For her, it was a fairly routine case. You know, she didn't have to go anywhere, didn't need a retina specialist, didn't need a second surgery, and it worked beautifully. So it's really nice to have that. I think it increases your confidence walking into the operating room that you have an alternative if your Phaco stops working for you. Posterior capsular rupture would be another potential situation, a dense cataract that you maybe misjudged, thought you were able to Phaco it a little better than you could. Technical malfunctions, Phaco machine goes out, electricity goes out, and you know, in the United States we don't think of that all that often, but I've had it happen. Actually, I've had a Phaco machine stop working on me. And I was in an outreach hospital. They only had one Phaco machine. There was no backup. We were able to get through it, but had it happened earlier in the case, I might have had to convert to an M6. So if you're converting from, this is my method. I won't say it's the best or the only way, but this is what I have done. It works in my hands. If you're converting to M6 from a clear corneal Phaco approach, if I turn that way, my microphone doesn't work, so I'm going to turn this way. The red line is my clear corneal incision, and what I do is I just take the conjunctiva down, maybe do a little cautery so I don't get so much bleeding, make my M6 wound. I kind of ignore my clear corneal incision. I just wound under wound and make my standard M6 incision. Now we've got a big enough opening to take that whole nucleus out, do what I need to do. It's also a beautiful wound for an anterior chamber lens implant, and I'm done. If you don't feel comfortable, let me go back. If you don't feel comfortable going wound under wound, you can rotate it 90 degrees, and I've done that as well. But in my hands, it seems to work quite well. I've not had a problem. I've had to do this, a number of times, and a number of times actually abroad. I was teasing with somebody the other day. Sometimes you go abroad and they'll have a Phaco machine, and you're primarily there to do M6, but they'll save the MVP patients for you to do. And you're jet lagged, and it's the first day there, and they want to have Phaco, and you've not seen them pre-op. And I had 2 patients in a row that had that kind of hanging nucleus thing in an MVP patient outside of the country, and converted both of them this way, and they both did great. So it does happen. It's not that common, but it's really nice to have some kind of alternative when you need it. Okay, other possible indications, secondary lens implants. This is totally my go-to wound for putting in a secondary lens implant if somebody needs an anterior chamber lens. And also it opens that world of opportunity to serve in regions of greatest need around the world. Without this tool, you are of limited usefulness in the most needy parts of the world. So thank you.